Oh. So, Gina, we will give a brief introduction of yours, then your presentation, and after that, we can take some questions. So, how much time do you have to give us?
I have 1 hour.
1 hour.
Yeah.
Fine. And your presentation is for how long?
It should be around 40 minutes.
Fine. So, we'll have questions after the talk is over, not in between, right? Yeah, that will be better.
That would be better. Yeah.
Great. So I need to do my throat thing because I'm going to introduce you someone very dynamic. And I've been meaning to have you on this series for such a long time. So I'm so glad it is happening finally. All right. So now this is how many people have joined. Kanika, how many have joined? Let's see. Kanika, can you hear me?
Ma'am, 55 have joined.
So do you think we should be waiting for some time? This is exactly 5, maybe a few minutes.
Yes, we can wait for 2-3 minutes. Yeah. People are joining. We are live also on YouTube.
Oh, you're live? Okay. Okay, then in that case, because Dr. Gina has just an hour to give us, it's very early morning for her and she has to join her practice. So we should get started.
We can start.
Yeah.
Yes, ma'am.
So,
Okay.
yeah. So first of all, formally, thank you so much on behalf of, we have, this is three consortiums which have come together to hold this series. One is International Bacteriophage Research Consortium, and OSPF, which is Open Source Pharma Foundation, and in collaboration with the Indian Phage Society, which is called as SBRT, Society for Bacteriophage Research and Therapy. And we have Dr. Gopalnath, who is a very senior member. He's the founder of the society. And I see Dr. Ramesh, who is the secretary of the society. He's also present here. Hi, Ramesh. Good to see you. So I would like to... Hi. So I'd like to go ahead with introducing all of you to Dr. Gina Sir. She's an MD from Mayo Clinic, and she is an infectious disease specialist with expertise in the field of musculoskeletal infectious diseases. Before she was in Mayo Clinic, where she joined in 2019, she created a musculoskeletal ID program at Stanford University Medical Centers in California in 2012. She has special interest in biofilms, bacteriophage therapy, and has publications in journals which include Science, Injury, Journal of Orthopedic Research, and Techniques in Orthopedics. She has received several honors and awards, which include Kenneth L. Wosti, MD Infectious Disease Teaching Award in 2018, and Career Physician Award for her work at International Center for Diarrheal Diseases, among others. And she's a member of several professional antibodies. And recently, in the early part of this year, she had worked on a patient, she had treated a patient who had a recalcitrant infection. And the unique part of this treatment was that phages were given to a heart patient whose implanted device had been chronically infected. So she treated that, and then the patient was good enough for heart transplantation. So it was a huge success case and a very tricky case to deal with. So hats off to Dr. Gina for holding it so well. And now she's going ahead with on a much larger scale, and she's also planning to do some clinical trials on phage therapy. So with that introduction, I would like to invite Dr. Gina to share our experience. And just to let you all know, this is a talk series. We are starting with Dr. Gina, and the aim is to have the clinicians share their experience because they know the best. We have held several talks before from the researchers, and as you all know that basic research, basic biology of phages is very important, but finally it is the clinicians who deliver them to the patients, and their success stories are hugely inspiring for this science which is coming up in this century very fast. So with that, I invite you, Dr. Gina, for your presentation, and thank you once again from all of us to join here.
Well, thank you so much, Dr. Ormi. It's my great pleasure to be here. It's wonderful to see all of you virtually. I'd like to take a little bit of your time to talk about my experience as a clinician with phage therapy. So I do have a couple of disclosures. I have positions at two different, actually three different commercial partners, APT, Phagelux, and Phage. So I wanted to get started here by asking all of you to get out your smartphones and just take a picture of that code or join at slido.com. I want to see from this audience how many patients, phage therapy patients, have been treated. So I'll give everybody a moment to do that. So 5 people have weighed in, and it's okay because it's I don't want to take too much time with this, but this at least gives me a sense of how many patients have been treated and what percentage of this audience might be in a similar position to me. So the majority have not treated patients, and that's great to know. Okay, so today I'm going to talk about, why phages, what role can phages play for my patients, and try to understand the complexities and the barriers from the clinician's perspective. I know everybody in the audience probably knows this, but in case there are people who are new to phages, phages are the viruses that infect bacteria. They are, I have come to see them as nature's natural predator of bacteria. They're the most abundant organism on Earth. And they've been actually used for the last 100 years for treatment, but they have not been FDA approved, and there's really not a commercial product kind of on the market. They do have an excellent safety profile, however. When you compare them with antibiotics, it's important to remember that these are very different, completely different from antibiotics. They are not a static molecule. They're a living organism that responds to bacteria and self-amplifies. And then, of course, the extremely narrow host range of phages are unique and makes personalization and thereby commercialization. So personalization is required, and thereby commercialization can be very challenging. And if I'm honest, I think antibiotics are much easier to use than phage therapy. However, phages can maybe do some things that antibiotics can't do very easily, such as treat multi-drug resistant organisms. Some phages are even felt to have some antibiofilm activity, as they can release depolymerases from their tail fibers. And they might be able to treat mycobacterial species and better than antibiotics because oftentimes multiple toxic antibiotics for very long periods of time make treatment of mycobacterial infections very, very difficult. And this is a patient who had disseminated Mycobacterium chelonae that was treated with phage therapy. And then another thing that phage might be able to do is potentially resensitize bacteria to antibiotics, and we'll touch upon that a little bit later. And then treatment with short courses or even one dose has been well recognized in the literature. And this is because of this sort of self-amplifying nature of bacteria. They have a very good safety profile, as I mentioned. They have been given a generally considered as safe or GRAS status by the FDA. And there have been numerous reports, case reports, and even clinical trials reporting safety. And the mechanisms of any adverse events are felt to be due to endotoxin release from the lysis of bacteria or from the bacterial components that could be part of the biomanufacturing process. But phages have become more in the spotlight because of mycobacterial resistance, of course, and the fact that medicine is changing and that we are putting in more and more medical devices into patients. And these medical devices are life-changing and life-sustaining, but as we know, once they become infected and biofilm is formed, it's extremely difficult to eradicate. There's been a long history of phage therapy, and I was lucky enough to go to Tbilisi, Georgia, where they have been utilizing phages for the last 100 years and have developed a very good system there. And they have very expertly developed good cocktails that are off the shelf, and occasionally will personalize treatment, but this off-the-shelf approach has a lot to do with the phage scientists, their experience and their sort of intimate knowledge of the local flora, and that evolves and it's tweaked every so often, every 6 months or so, I'm told. The Western world, Western medicine sort of abandoned phage therapy with the emergence of antibiotics, but this started to change in 2016, 2017 with this now famous case of a patient who had developed a multi-drug resistant Acinetobacter pancreatitis and was really turned around after the start of phage therapy advocated by his wife, Dr. Stephanie Strathy. And then this famous case, of course, is one by Dr. Hatfull, who I've seen I think on this series before, but Dr. Hatfull and Dr. Dedrick treated a 15-year-old girl with cystic fibrosis with phage therapy who had Mycobacterium abscessus that disseminated, and she was not responding to antibiotics. She couldn't tolerate them, and phage therapy was given, and she actually went on to live several more years after this. And if you look at the literature, you will see tons of examples of case reports where phage therapy seems to play a role. Now, I'm a musculoskeletal ID doc, so I have a bias toward those types of case reports, but this is just a tiny sampling of the case reports that are out there. And panel A was interesting to me because I deal with many diabetic foot ulcers and diabetic foot ulcers leading to osteomyelitis. And Dr. Fish in the US, I think in the Seattle area, gave this patient weekly injections of phage directly right into the joint, into the toe, and in his clinic. And you can see that the wound healed, the ulcer healed, and there even seemed to be some bone formation. Panel B was a patient in Israel who got into a car accident and had a traumatic tibial injury with indwelling hardware infection. And he had multi-drug resistant organisms, and that was treated. Panel C is a 7-year-old girl out of Australia who had a multi-drug resistant Pseudomonas infection that was treated with intravenous phages only. So not topical and not intraoperative, but intravenous. Panel D is out of Germany, a case of a prosthetic hip infection. And then E, I think that was an LVAD from San Diego. And then F was a case shared with us from Tbilisi, Georgia, of a patient who had this wound for decades and finally responded with topical phage therapy. So the crux of my talk today is really going to be about our experience at Mayo Clinic and who we've treated, how we've treated them, and kind of what our considerations have been and what we've learned from these cases. So we've treated 15 cases. This is 13 unique patients, but 15 cases. And they have been mostly, a large number have been prosthetic joints, 2 LVADs, 3 non-CF bronchiectasis courses, 1 hepatic abscess, Mycobacterium abscessus mastoiditis, a peritonitis, and a vascular graft infection. So how did we go about treating these patients? And maybe at the end, when we have a discussion, I would love to hear from you what the process is in India for compassionate use. But in the US, there's only 2 ways to obtain phage therapy. The first is through clinical trials, and the second is through compassionate use. Compassionate use, it's a pathway offered by the FDA that allows clinicians to give medications if, in our judgment, we feel that the medication can benefit a patient who has exhausted all other options. And so we are tasked with sending in an application for an investigational new drug. If it's not an emergency, if it's an emergency, then an EIND, or an emergency expanded access application, has to be filed and reviewed by the FDA. And usually there's like a little back and forth where they ask questions. They have to ensure that the product is of quality and can be given safely to patients. So the compassionate use pathway is what we have used to treat all of our patients. The process at our institution looks a little bit like this. First, the patient is identified and referred to me or my program. And these are colleagues, a lot from infectious diseases, and then other departments also refer patients. And then this is where so then there's a request that's made and the case is reviewed. And I think this is where our expertise is starting to, make a difference because it's a bit of an art form to select cases that we think would be appropriate cases for phage therapy. After the patients are selected, the phage, the bacterial isolates are sent out to some of our partners. We have partnered with different laboratories, and I'll talk about one of them, but either academic or commercial. And there's a process for screening and identifying a phage. And if there is a phage, then a therapeutic plan is made where a protocol is established. And that part is challenging because there's been so few patients in history treated with phage therapy, and there's many more treated with antibiotics. So the protocol development piece is non-trivial, and then we deliver the phages and arrange for that. So one of our academic phage scientist partners is at Baylor College of Medicine in Taylor Labs. And we work with Dr. Anthony Moresso, Dr. Austin Terwilliger, Dr. Kiko Salazar, and Dr. Liu, Carmen Liu. And they are, in the US, the only end-to-end pipeline that can receive bacterial isolates. They have a discovery pipeline, and then they have a biomanufacturing pipeline. And probably a lot of you, may be involved in this side of things, but Taylor is excellent, and they provide a comprehensive report where they give us the process of their protocols for manufacturing, documentation of any susceptibility testing or lytic activity. They tell us about endotoxin levels, sterility testing, and also antibiotic synergy reports too, which they call sinograms. And these are all very important documents to be able to give to the FDA to help justify and prove, rightly so, that we are being safe and we're doing everything possible to help and keep our patients safe. So the 15 cases at Mayo have, I've kind of told you already about the indications. The organisms are listed here. We had 3 Staph aureus cases, so a lot of staph. So a Staph epi, a Staph lugdunensis, Pseudomonas, E. coli, 2 Klebsiella cases, 2 E. faecalis, a Staph epi, and an M. abscessus. The routes of administration have been very, I think this is one of the most important pieces when considering phage therapy is the route of administration. And our approach has been to give phages via as many routes as we can to try to ensure that we have the maximum number of viral particles getting to the site of infection. And so our first patient we treated with IV only because we didn't have experience with direct administration or topical delivery. But every patient subsequent to that, we've treated with IV or directly into the joint or directly into the abscess cavity, or nebulized if it's a pulmonary infection, or even right into the abscess cavity with a vascular graft. One of our patients had a peritoneal infection, and we gave phages, administered them directly into the peritoneal cavity. And I'll talk more about these cases in more detail. So when one is considering cases, we look at the syndrome, we look at the organism, and by that I mean there are certain organisms that are more where there's more lytic phage options. There's more laboratories working on them. They seem to be more available. They have more, proven or more case reports supporting lytic activity. And those are the ones that I mentioned: Staph aureus, Pseudomonas, Klebsiella pneumoniae. So the bug is important. It's also important that we have the actual bacterial isolate in hand, because the screening process requires the organism to be physically available. And the tempo of the infection is how acute or chronic the infection is. And because phage therapy is at a stage right now where immediate or rapid turnaround is not possible, we are unable at this time to treat highly acute infections where things are rapidly progressing. So the typical infection that we treat is a serious chronic infection that has been refractory to other treatments. And that's where previous treatments come in. Typically, we would treat patients who have failed conventional treatments, and partly because that's a requirement of the FDA that we cannot ethically offer a patient phage when they have not already tried the standard of care treatments that are available. Going back to syndrome for a second, there have been many syndromes treated with phage therapy, and I don't believe that there's a limitation to the syndrome. But the syndromes that have been most commonly treated have been bone and joint, UTI, pneumonia, and prostatitis. And I'll give you a few numbers on that a little bit later. So getting into our cases, I want to take a few of our cases and highlight them and kind of walk you through our thinking and our thought process with these. So this patient, Dr. Urmi actually mentioned him. He's a patient with, he had an ischemic cardiomyopathy and had a left ventricular assist device placed in 2018. It was a destination LVAD, so it was intended to be in place indefinitely because he was not initially a candidate for transplant, for heart transplant. And then he developed a Staph aureus infection that began in the driveline and recurred over and over again, despite long courses of suppressive antibiotics, both oral and IV. He was even taken to the OR by our surgical partners for surgical debridement and had an irrigation debridement and omental flap reconstruction. But despite this, he continued to be actively infected with multiple hospitalizations. So we partnered with Baylor, and they were able to come up with a 2-phage cocktail, and that took several months. It actually took about 6 months to arrange this, but 2 days prior to the scheduled admission, the patient presented like this, with kind of pus kind of really pouring out of the driveline site. And so the timing actually was miraculous in that we were luckily ready for him, and we were able to treat him with phage therapy. Our surgeons at that point had agreed to take him for a VAD exchange. They had not been willing to do that up until that point because of the high morbidity. But because we were able to offer something else, like phage therapy, in addition to antibiotics, they agreed to do it. So that was a wonderful partnership with them. This diagram on the right is a sinogram. So this is an example of the assay that Baylor has that looks at interactions between antibiotics and phage. So we see here the top, and I'm sorry, it's very hard to see, but the top row is ceftriaxone and the bottom row is cefazolin. And where you see white is clearance. So that's lysis, just like a plaque. Where it's clear, there's lysis. And where it's orange, there's no lysis. So you can see that that actually ceftriaxone seems to be a better choice here because of the white, the clearance with the combination of ceftriaxone and the phage cocktail. So we went ahead and gave him, all this treatment, phage therapy, antibiotics, LVAD exchange, and he did extremely well. I mean, surprisingly well with this degree of, bacterial burden. And our surgeon noted that usually after an LVAD exchange with an active infection, the patient goes into sepsis. They develop SIRS symptoms and signs, and they become hypotensive. They're in the unit. They need pressor support for a few days. And this patient did not. We didn't see that, for what it's worth. You know, it's an observation that we noted. And the patient went on to clear his infection. And we had some PET CT images that we took, and we see kind of a progressive improvement of the PET imaging. And then after some time, you know, we even stopped imaging him, and he even stopped coming to clinic. And he went on to have a successful heart transplant. And the patient is, you know, living essentially a normal life now. So that was very gratifying. Our second LVAD case was a different organism. This was also a destination VAD. It was with Pseudomonas aeruginosa, and it was a driveline infection. And unlike the other patient, this patient had an infection that was really localized to the driveline site. But Pseudomonas was resistant to fluoroquinolones, and despite long, years of suppression, he still had this draining wound that you see there right in the middle of the picture. So we took him to surgery. Our surgical colleagues did. Again, a partnership with Baylor with the 2-phage cocktail. And we decided to give phages both intraoperatively, so 1 dose intraoperative. And then we left a catheter in place. So that small catheter on the top part of the picture that's outlined in the blue box is a catheter that the surgeons left in place for the purpose of delivering topical phages. And the white line is the drive line, and the sutures are over the abscess cavity. So the surgeons took him to surgery, washed out the abscess cavity, administered topical phage, and then for 4 days or so after, we administered phages through that catheter. We did have some problems because that catheter was too small, and it kept clogging. It kept getting clotted off with coagulated blood. So and this was after we intentionally tried to find a very small catheter. So we actually looked for a tiny catheter because we thought that would be good to have a small catheter in there. And it was like a pediatric biliary catheter that we chose, but it ended up being too small. But nonetheless, we were able to administer four doses postoperatively. And he did great too. After about probably 6 months or so after, so we were unsure of when to stop his antibiotics because his post-procedural PET scans still showed a tiny bit of uptake, even 7 months postoperatively. So we were hesitant to stop his antibiotics for fear of relapse. But what happened was the patient decided that he had enough of antibiotics. He was having really bad side effects to them. So he self-stopped his antibiotics, and he was right, because the infection never came back, and the drain is no longer, the wound is no longer draining, and the patient has been off of antibiotics for probably 18 months now. So a couple of reflections before we move on to other cases is, how to determine the route of administration. Again, we feel this is very important, and trying to find a way to directly administer phages with partnerships with surgical colleagues has turned out to be essential, we think. And then how to determine dose. I didn't really talk about dose in the cases, but The typical dose that we've been working with is somewhere around 10 to the 9 or 10 to the 10 PFU per dose. That number is probably could use more sort of scientific justification with PK studies, but 10 to the 9, 10 to the 10 is now kind of becoming quite standard. I don't want to use the word standard because it's not standard, but it's becoming common. But if you look at the Georgian practice, the Georgians will tend to use a slightly lower dose, maybe 10 to the 8 or so. And I think, mostly the limitations are to ensure that we're not exceeding any endotoxin limits. But I really haven't seen dosages beyond 10 to the 10. How to determine frequency, again, more robust pharmacokinetic studies are likely needed in humans. But a Q12 twice daily type of, once to twice daily type of frequency is what we're seeing most commonly. The Georgians will sometimes do a continuous infusion. So they might do a lower dose, but more frequent. And in the US and Western Europe, to some degree, are maybe doing higher doses, but at fewer times a day. And then the last thing we struggle with is how we measure success. For both of these cases, we treated the patients with surgical debridement. And in the first case, we even took out the entire LVAD and replaced it with a new one. So how can we really say how much the phage contributed to this outcome? I think that's a really difficult question. We have some historical data that we can look at to tell us what the typical success rate is with a LVAD exchange. But that would be, that's an approximation. And for this particular case, we just don't know. So that's something we struggle with. What is the role of phage therapy in surgical infections? This case I want to highlight because it was very interesting to us. This was a PJI case, our first one actually, of a gentleman who had a long-standing recurrent polymicrobial right total knee infection for which he had multiple surgical interventions. And this patient was also allergic to pretty much all the antibiotics that we gave him. And he had very severe reactions, including a Stevens-Johnson's reaction to one of the antibiotics. And he developed yet another infection in 2019 with Klebsiella pneumoniae and presented to us in a lot of pain, with a lot of disability, and unable to live his daily life. And he was offered a high amputation or hip disarticulation because of the extent of the endoprosthesis. He had a large prosthesis because of the number of surgeries he had had. So at that time, we partnered with a phage company that they were able to biomanufacture a intravenous phage, and this was a monophage. It wasn't a cocktail. It was one phage, and we gave him 40 intravenous doses as an outpatient. And the patient who was allergic to everything had no adverse effects whatsoever to phage, and his pain resolved. His flexion, his range of motion improved from 45 degrees to 90 degrees, which allowed him to bend his leg enough so that he could sit in a restaurant, sit in an airplane, sit in his tractor without difficulty. And that really allowed him to kind of, it improved his life tremendously. We did continue his oral minocycline throughout the whole course because of all of the other bacteria that he had that it was suppressing. We did not feel that it was justified to stop the oral minocycline, so we did continue that. But our patient is doing very well, and objectively, some data that we have is that it seems like some inflammatory cytokines and inflammatory markers seem to decrease over the course of the phage therapy. I don't think anyone really knows what that means at this point, but it was something we observed. Notably, this was 2019, and this was the first PJI to be treated with phage therapy and without surgery. And this was a kind of proof of concept that phages, because antibiotics can't do this. We know that. So this is kind of a suggestion that perhaps phages can do some things that antibiotics can't do. Including things like, treating what we consider to be surgical infections. But we did go on to treat several more PJIs, and none of them had the degree of success that our first patient had. And I can't tell you why. I mean, that's still unknown to us. But our first patient had a high degree of success, and then subsequently, we didn't have that degree of success. We were clearing infections only with additional surgeries. And that could be because of the severity of the cases. I mean, you can see from this picture that the soft tissues of these patients were not good. The patient all the way on the right had a really severe lymphedema. The patient third from the left had this chronic pocket that had filled up with this seroma, and it was, we couldn't clear the infection, and I think that was a really high bar to set because of the chronicity, the poor soft tissues, and the fact that this fluid collection was chronic. It was it was not, optimal for eradication of the infection. We treated some non-CF bronchiectasis cases. This one was an 85-year-old male with long-standing colonization with multiple organisms, including Klebsiella, Pseudomonas, Staph aureus, and Stenotrophomonas. And he was relapsing with symptoms of infection every few weeks. So we treated him with a combination of 2 weeks of nebulized and intravenous therapy. And it was really interesting because the sputum seemed to completely clear in the first week. So this is a patient who never has a clear sputum. But he had no growth of bacteria in the first week or so. But in the subsequent weeks, of course, he developed at least colonization again, and then eventually clinical infection again. I don't think it's important to clear the sputum. That's not our goal with CF or non-CF bronchiectasis patients. The underlying anatomic abnormality is unchanged, and so we wouldn't expect there to be a durable clearance of colonization. But it was interesting that we saw that, and perhaps suggestive of the fact that the phages at least got in there. So some reflections on this was that for CF or non-CF bronchiectasis, the challenges of this clinical indication is that these infections are often polymicrobial. There's multiple strains. It's usually Pseudomonas and a mycobacteria. And there's usually multiple strains of each organism. So it's really difficult to say whether it's appropriate to treat only some subset of the multiple organisms and multiple strains that you might find. And you know that once you start treating some of them or all of them, there's going to be more and more. So that makes this clinical indication really challenging. The underlying anatomy doesn't change. So the impact, the duration of impact would be temporary. And we know that that patients with bronchiectasis will need multiple courses of antibiotics and phages without ever really clearing the infection. And then figuring out the multiple cocktails. We have IV, we have nebulized, we have multiple antibiotics. It was also challenging too. For the sake of time, I'm going to talk about these last two cases, which I thought were really interesting. This is a peritoneal infection, a case of a 58-year-old gentleman who had undergone heart-kidney transplant. He had a recurrent multi-drug resistant Pseudomonas because he had an infected diaphragmatic patch that was a consequence of surgery. And retrieving and removing that patch was going to be highly morbid. So phage therapy was considered, but we couldn't get phage therapy fast enough. So he went ahead and went to the OR to have the patch removed. But despite that, he actually relapsed with Pseudomonas peritonitis again, even after the patch was removed. So that's when we were able to finally give him phage therapy. We gave him 14 days of IV phage and 6 doses of intraperitoneal phage, which I think this is the interesting part of this case, is that we gave it intraperitoneally. And it was my team, my fellows at the bedside who first drained the peritoneal fluid. Sometimes there were 6 liters that we would drain, and then we would administer phages with the idea that we wouldn't want to over dilute the phages in the peritoneal cavity. So we first had to drain the fluid, and we did this 6 times, and the Pseudomonas cleared from the peritoneal fluid. However, the patient was extremely deconditioned and frail. He had been in the hospital for 9 months, and we gave phages in the 8th month of his hospitalization. And unfortunately, in the 9th month, he did succumb for other reasons. This case is really fascinating to me as well. This is a Mycobacterium abscessus mastoiditis in a young, healthy woman who's a mother of 4. And this impacted her hearing. She had some partial hearing loss in her left ear. And Dr. Hatfull and his team at the University of Pittsburgh came up with a 2-phage cocktail that we delivered again in the mastoid, into the mastoid during surgery, and then we left a catheter. Our ENT colleagues left a catheter in place through which we gave phages, and that catheter stayed in place for about 5 weeks. And in addition to phages given through the auditory canal. She's still undergoing treatment because NTMs are treated for long periods of time, and she seems to be responding with improvement in her drainage and hearing. So we'll see. This is an ongoing case. And then lastly, just quickly going through this case, this is an ongoing case as well, really interesting. It's a 65-year-old female who had pancreatic adenocarcinoma and had extensive surgery, including pancreatectomy. And she had a portal vein graft that was placed that was complicated by an MDR Klebsiella infection and abscess formation. And she had this infection suppressed for 4 years before finally it broke through, and she became symptomatic with obstruction, and became hospitalized recurrently for cholangitis. So that's when phage therapy was initiated, and we gave phage for 14 days, and intralesional phages. So we injected phages with the help of our gastroenterology colleagues. We were able to place the phage right into the abscess surrounding the graft through endoscopic ultrasound. And then when we went in and repeated cultures, there's no more Klebsiella. So that was, we thought, very gratifying. However, she had multiple other cultures that were positive, probably because of increasing contamination and possibly even fistulization with the portal system and the biliary system. So we don't really know the true success rate of compassionate use. These are uncontrolled studies that definitely have some publication bias, and defining success is very tricky. And as I alluded to, much is still unknown with efficacy, dosing intervals, PK/PD, optimizing stability. We don't test the stability of the phages probably often enough to ensure that they've survived transport and survived storage conditions, etc. We are still working on optimizing delivery of phage to the site of infection, but we still don't know what is responsible for this discordance, because we do have in vitro data of lytic activity, but that doesn't always translate to in vivo, and that's the case with antibiotics as well. We don't really know the role of the human immune response. We don't think that there's neutralization antibodies that play. We don't think that plays a big role, but that is yet to be determined. And we are still working on optimizing synergy with concurrent antibiotic therapy. So I'm going to skip this for the sake of time, but what about clinical trials? There have been multiple clinical trials. There have been at least, I think there's 16 now. Several more since I even wrote this slide. But the reasons for failure of clinical trials have been attributed to perhaps underdosing and failures of stability, and the use of fixed cocktails and lack of individualization. Because phage therapy is an inherently personalized treatment, and clinical trials are inherently depersonalized because you want the findings to be applicable widely. There's been this tension between clinical trials and need for personalization, but more recently there have been ways to personalize treatments within clinical trials. So I think that's kind of a new frontier of clinical trials. I'm going to end by highlighting my favorite case in phage therapy, which is this one, which I'm sure many of you are aware of already. But this particular case really sets up a model for rational approach to phage therapy. And so what Dr. Chan and his team did at Yale was to understand what receptors this particular phage binds to, this phage called OMK01. And this phage binds to receptors that mediate antimicrobial resistance. So by targeting those receptors, there's been an evolution, a trade-off of resistance mechanisms, and this has led to a resensitization of this bacterial strain to antibiotics to which it had previously been resistant. So I think more of that is in the future, where we are looking very precisely at exactly what receptors are being targeted by these phages, and then harnessing that and utilizing that to our advantage. I'm so sorry. If people are interested, this is a document that we put together for clinicians who are interested in phage therapy that gives some kinds of considerations or loose guidelines for clinicians. And then please join us for our global clinical phage rounds. If you are a clinician interested in phage therapy, you are welcome. You just have to sign up and contact me if you don't have that link. And the last two sessions were with Dr. Koff and Dr. Van Tine and Dr. Hayter at Yale and the University of Pittsburgh. Okay, so I will end there. Many thanks to you all for being here, for Dr. Urmi, and I'll take any questions. Thank you.
Thank you. Thank you so much, Gina. That was excellent, almost end-to-end presentation, right from telling how you started and then the success stories and the challenges. I see several questions here before I take the questions, I wanted to ask you that in any of the cases, did you find resistance to phages emerging in those? Because these are all like long run therapies, several months. So you either did monotherapy or there were two phages. So did you see any occurrence of phage therapy, resistance to phages anytime?
Yeah, in the few cases where we checked, we did not see resistance. There was one of the PJI cases that where the bacterial strain that was cultured after the failure seemed to no longer be active against the phage. We don't know if we didn't do the sequencing to see if this was development of resistance or if this was simply a different strain. So we have not seen phage, but we didn't look in all of the cases. That's something that is needed.
Yeah. Seen as in if they're resistant, then they might stop acting. And what would be the cost like, it being such a personalized medicine? How has been the cost for the patients?
So we've been lucky in that we don't charge the patients. So it's free to the patients. The patients still have to pay for things like transportation, and they have to come here and they have to live here for a few weeks. We also they probably incur some costs with the other treatments like the concurrent antibiotics, but insurance covers a lot of that. So the costs to our patients have been pretty minimal. And so the phages are actually paid for by our grant funding in our program. But also they've been given to us pro bono in many cases by our very generous and excellent, partners.
And this permission to go for compassionate therapy, is it case by case in your Mayo Clinic, or is it given for some? I mean, is it case by case or what?
It is case by case. So we for every individual case, we have to go through the same process. And we try to do like an umbrella IRB. But the problem with that is that each phage is different, right? So each cocktail is different. Each phage is considered to be a different therapy, which requires like a different, lab manual or different protocol for purification and everything. So our IRB would not accept an umbrella approval.
All right. So I think I've asked several questions which are written in the chat box. One is from Dr. Shai Jameel. He is virologist from India. His question is, this time is lost in critical cases if phages are to be selected for each patient. So are we having a system where phage stocks will be available for particular strains, especially the nosocomial infections causing bacteria? So if there are bank of those clinical isolates and then bank of phages against those.
Yeah, I agree. I agree with this statement. I think it's important to have both. So, I think there will be a role for personalized therapy. And I think that will become faster with time. But to have kind of a broad spectrum, broad host range fixed cocktails will be very important in the future for maybe more simple infections, maybe UTIs and other things like that. Similar to what the Georgians do, where you have a very intimate knowledge of your local bioflora, and you're able to create phage cocktails in advance.
Okay, Dr. Gopala, would you like to share your experience with starting with broad spectrum phages and then narrowing down?
Yeah, Dr. Urmi, thank you very much. And it was really wonderful, very illuminating lecture. So thank you very much, Gina. And what we have done some preclinical studies and clinical studies as well. So we have found in one case we have treated recently the lung infection by Acinetobacter baumannii. And we found that if you give the very small dose and continuously in infusion, say you are taking 100 ml of the normal saline and mixing 10 per 5 PFU per ml, 100 microliter only. And then you can monitor the blood pressure and also the oxygen saturation. So that gives the indication of the situation, what is happening. Even if there is the bacterial lysis and leading to release of a lot of endotoxins, those endotoxins, what they are doing. So we can monitor the slow release of endotoxin. This is our experience. And the same thing we have done in case of preclinical studies also. And about the duration of this one, about the duration, then about the frequency. So about the frequency, actually preclinical studies says that 2 or 3 doses are sufficient for the septicemia, but localized infection, if biofilm formation is there, especially in case of prostatitis or chronic bacterial infection, then 3 to 5 doses are needed if you are giving per urethra. So we have treated some of the cases like this also, and several doses are required in case of the chronic infection, but in case of acute infection, 1 or 2 doses is sufficient with the monitoring. So we have seen and we have done also with very lower dose, that is 10 per 5 per dose. So that is sufficient. But for the local infection, topical use, we can go for the higher concentration of the phages. So that is my point. And I think it was really very interesting. And what is the problem with the compassionate ground is that can we use the GMP phases, or we are just having the customized phases and then we are using it? Should be, and we don't know the status of the virulence genes and the this resistance gene as well. So I don't know what Indian government will be doing, but we have done few cases on the compassionate ground, and we are about to process this one. So this is the thing, and it will be great that we are having the broad spectrum phases fully characterized in our stock or in our library. And like antibiotic disc, we are testing and then making the cocktail right now, and then we can dispense to the patient. So this is really very encouraging and promising as well. So I think we should go for the phage therapy in India also, and we are trying to convince our administrators and regulators so that they are permitting us. Okay, thank you, Gina, very much, Dr. Urmi. That was the great show. This organized by you. Thank you very much once again.
Last thing, or Dr. Sanjay Chibber, sir, are you here? You have experience with diabetic foot ulcers. Do you have any questions? Because I think Dr. Gina mentioned that in the beginning of her talk. Dr. Sanjay Chibber, are you there? Okay. So then I'll just take, Dr. Gina, please allow me to take a couple of questions from the audience who have written it here. One is, I think the first is on the immune response. So have you come across, I mean, either they did not respond to the therapy, or was there an immune response to therapy in any of the cases that you have dealt with?
Yeah, so we haven't fully characterized that yet. We're in the middle of going back and looking at immune response. It's a really important question. You know, I think it's a very plausible. It's very plausible because you know, some cases we saw this tremendous response, and in a different similar case we saw almost no response.
Right. And Biswajit, he wants to ask, bacteria evolve those mechanisms for over as a natural process. Okay. So I think Nivedita is also here. She's from OSPF and she has several questions. I think two have been covered. So what particularly she wants to know, Dr. Nivedita Rath, is to what is the requirement from FDA to approve phages in the cases you have solved so far or treated so far?
Yeah, the FDA requires a report detailing the kind of procedure for biomanufacturing and processing and purification. And they also require a USB 71 report, which is a sterility report. So making sure that there's no bacterial, fungal, or mycobacterial contamination. And they want a clinical plan. They want to know how you are going to monitor for adverse events and what your plan would be if you run into any, and what the kind of monitoring follow-up plan is. They don't require, interestingly, they don't require sequences of the phage.
Oh,
that might be coming. I hear from the FDA that they might require. I mean, our partners all sequence and characterize the phages, but it's not technically a requirement right now.
Okay. So no requirement for screening phages for toxins or lysogenic genes or antibiotics.
Yeah. So for toxins, so we do have to show in vitro lytic activity, but we don't have to show sequencing data.
Okay, that says all right. And one more question: can we extract lactate lysate enzymes from the tail fibers of phages? So Arnav wants to know about the phage lytic enzymes, if they can also support phage therapy, like the way antibiotics do. So
like lysins.
Yeah, license.
Yeah. Yeah, so lysins are, in my opinion, very promising. There's a huge potential for lysins because you're essentially bypassing the this virus that's, this other organism, and you are essentially bypassing that and taking the end product and utilizing it. I think there's pros and cons to lysins. One is that it behaves much more like a fixed molecule, like we're used to. So that could be a pro. But one con is that it doesn't have the same self-amplifying and co-evolutionary ability like phages do.
Okay, one last question. This is a practical question, I think, from phage researchers who keep isolating phages and keep getting some bacterial contamination. So how to avoid bacterial contamination while preparing phages? Are there any columns? I mean, what is the stringency of phage preparation while using for therapy? How to purify?
I wish I could answer that question. I've never purified a phage in my life. I've only given them. So that would be a great question for my colleagues.
That's right. And
Urmi, can I ask one question?
Yes, please. Yes, please, sir.
Yeah.
I was asked for.
Yeah, in fact, it was on mute. I was speaking, but you couldn't hear me that time. Yeah, Dr. Gina, I want to ask you one question. Have you used any dressings or topical applications like creams and all the hydrogels which are being developed these days by the scientists for the topical application?
Yeah, I have not personally used them. We were involved with a clinical trial that utilized microcapsule delivery for topical phages in a spray form. That seemed to be very promising, but that trial did not take off. That's on hold for now. But I've seen the reports on hydrogels, and I think that's extremely important because delivery and stability are such issues with phage therapy that coming up with a hydrogel or a delivery system is going to be very helpful.
Yeah, and the release will also be over a longer period of time.
Exactly,
So that's
right.
an additional advantage. Yeah. Thank you so much. Thank you.
Thank you.
Right. I think with that, since you have to leave, there are several more unanswered questions, but if we go for, yeah. So, but then I think we have to let you go because you have, I think, the hospital to attend. But
Well, yeah, I'm working today. Today's a holiday in my country. It's Thanksgiving, so happy Thanksgiving, everybody.
Yes.
But I do have to get to clinic because I'm on duty today.
thank you so much. We really, really appreciate your time. And I think it must have cleared a lot of doubts because it's an enigma for most of the people here. We are not doing compassionate therapy as yet. So how people do elsewhere and how is it actually administered is something a lot of people in India still don't know. So that's why we have started with this series, and we are so grateful to you for sharing your experience so lucidly. It was very clear. I think most of us would have got it quite right. So I'm sure that this would also help us chart our own ways and look for how to make phage therapy happen in India also, even to start with on compassionate grounds. Thank you so
Thank
much.
you so much. It's my pleasure and honor to be here. Thank you for the invitation.
Thank you so much. And thanks
Thank
to the
you.
participants for being here and for asking such good questions. So with that, I thank Ritu for managing the whole show from behind. So she has been like sending invitations and holding, I mean, she's the one who's behind this show, I would say. So thank you, Ritu. She's not well, but thank you so much, everyone. Thank you. Bye-bye.
Thank you,
Bye.
ma'am. Thank
Bye.
Bye. Bye.